Good evening, everyone. My name is Ashley Tucker, and I'm so excited to be with you this evening. I will be your moderator, and I would love to welcome Doctors Maria Walker, Gloria Chiu, and Vivien Say for our scleral lens research update. And just a little reminder, this is our finale webinar for the 2024 webinar series. I am going to introduce our speakers. So Dr. Maria Walker is a clinician scientist at the University of Houston College of Optometry with a lab focusing on keratoconus and ocular surface disease research. She graduated with an OD and MS degree from the New England College of Optometry in 2013, completed a cornea and contact lens residency at Pacific in 2014, and then a PhD in physiological optics at the University of Houston in 2021, investigating the impact of a scleral lens on the ocular surface. Maria is currently a tenure track assistant professor at U of H, where she is a clinical instructor in the cornea and contact lens service and runs a translational lab studying the role of inflammation and disease in contact lens wear. Dr. Gloria Chiu, is an associate professor of clinical ophthalmology at the USC Roski Eye Institute, Department of Ophthalmology at the University of Southern California, Keck School of Medicine. She received her Doctor of Optometry at the University of California, Berkeley School of Optometry, and completed a residency in cornea contact lenses at the Southern California College of Optometry, where she still serves as an adjunct faculty member. Her clinical interests include contact lens fittings and treatment for patients with ocular surface disease and irregular corneas. Her research interests include microbial contamination and contact lens related solutions and effects of scleral lens wear on the ocular surface and optic nerve. Dr. Vivien C. is a PhD candidate in vision science at the Herbert Wardham School of Optometry and Vision Science, University of California, Berkeley. She also serves as a research optometrist and clinical research project manager at UC Berkeley's Clinical Research Center. She received her optometry degree from the New England College of Optometry and completed a cornea and contact lens residency at UC Berkeley. Dr. Say's primary research focus is on the impact of scleral lenses on ocular surface health. She is actively involved in several patient-based research studies on scleral lenses, dry eyes, soft contact lenses, and lens care products. So as you can see, we have a powerhouse of ladies here with us this evening. All of their financial disclosures have been mitigated. If you guys have any questions, please feel free to use the Q&A feature. The chat feature also works fine, but we prefer the Q&A feature if you don't mind. In order to gain CE credit for this evening, attendees must remain online for a minimum of 15 minutes for COPE credit. You are welcome but not obligated to stay for Q&A at the end. And course handouts can be found on the SLS website library page. So I am now going to stop sharing and pass it over to our wonderful speakers for this evening.
Hi, thank you. Okay, I think that's me starting us off. So thank you, Dr. Tucker, for that nice introduction. And thank you to my fellow speakers. I'm very excited to be speaking with Gloria and Vivien, who have not done this with me in the past. It's been with Dr. Shornack and Dr. Vincent. So welcome to the team, ladies. I'm very excited. And I also have to say we have a little bit of a special event tonight because it is Dr. Say's birthday. So happy birthday to Dr. Say. So thank you for giving us your birthday present of joining us on this webinar.
Happy birthday.
And so how we usually like to start this is just sort of just summarizing where we're at right now with contact lens or scleral lens publications. So we always do a little PubMed search. And here, if we look under scleral contact lenses in PubMed 2024, you can see the number of publications sort of had been rising and is sort of plateaued a little bit, but on the high end. We ultimately came up with 34 different articles that we thought were sort of worthy of investigation. We are not going to go through all 34. We're going to hit the highlights. I think I'm going to do about 6 or 7 of the papers, and then Vivien and Gloria will probably take about maybe 10 or 12 of the rest of them. So the publications have been, as we usually see, we see a lot coming out of the US and Australia. We had several other countries represented as well, several papers out of Spain, and as well as India and some of these other countries. So well underrepresented. A lot of people in the world doing scleral lens research. These are some of the journals that we see represented. Pretty common: contact lens anterior eye and contact lens are two of the most common that we see. We also see things in IOVS, OVS, and some of the other ophthalmology journals throughout the world. So what I am going to go through in relatively rapid fire form are some of the papers. What we essentially do is split up the papers and sort of read all of them and figure out which ones we want to highlight for the year. And so I this year sort of got the papers, sort of extra papers that didn't fit into the other categories. So mostly about visual outcomes, but also some health. And with me, I of course have to report on what's been new with midday fogging research. So I'll end with that. But um, this first paper that I'll highlight actually was not in 2024. It was published at the end of 2023 in the Saudi Journal of Ophthalmology. And this was a quality of life and vision assessment with scleral lenses and keratoconus. This was a pretty simple, straightforward, pretty small sample size paper. I'm highlighting it briefly just because I think it's really important that we continue to publish on the good outcomes of scleral lenses. This type of paper can be cited in and referenced in all sorts of different mediums, from people writing grants to people working with regulatory agencies to say, yes, these are devices that can be used to improve vision in patients, specifically in this case with keratoconus, not to mention when we're communicating with other physicians. So they looked at 14 patients, and as all of us probably know on this webinar, the vision is going to improve with a scleral lens compared to spectacle lenses, as you can see on that table. And the other thing I think is nice, and again, just gives us some evidence that we can use to back up things that we know are true in our patient population. They also looked at the NEI VFQ, which is put out by the National Eye Institute. It's a visual functioning questionnaire. The blue lines here represent with a scleral lens. So basically every metric of quality of life, I guess, other than general health and color vision, are improved with scleral lenses. So if you're looking for evidence to convince people, this is one of the more recent publications that provides us with that. Staying on that visual track, this was a paper that was published in the European Journal of Ophthalmology this year. I thought this one was really interesting because one of the questions that we often get, and one of the things that we're often talking about, is what's the vision like in a scleral lens compared to an RGP corneal gas perm lens? And so that's exactly what this study was doing. They had 14 patients as well. Their patient average age was about 34 years old. Note that the Kmax was 63 diopters, which is a little bit the mean Kmax, which is a little bit on the steep side for most of these studies. So just kind of keep that in mind. This was a little bit more of a severe population. These actually were patients, if you read, it's always good to read the fine print on these, because if you look at the patients selected, these were actually patients who were having poor tolerance to their RGP lenses, and so were already going to be refit into sclerals. And so they looked at visual outcomes and they measured higher order aberrations with spectacles, RGPs, and scleral lenses, which is really cool. And we don't have a lot of studies that have done this. Here's what the tables look like. We'll kind of focus in on what I think is the most kind of important thing here, is that scleral lenses had less higher order aberrations. So coma, total higher order aberrations, coma, and trefoil. And if you look at one of my little pink outlines, that's showing what the root mean squares, which lower typically is better, lower is better in these cases. So total, coma, and trefoil in HOAs were lower in this population. So main conclusion of this, I thought it was interesting that, a lot of studies have shown comparable, exactly comparable vision. One is not better than the other in terms of comparing optics with GP and sclerals. This study was one that showed, and just one, but it's a study that shows better vision with the scleral lens compared to the RGP. The biggest take home, I think, is that this was in more severe keratoconus. So I think this does provide some evidence that in a more severe cone, the scleral lens may actually provide better optics for these patients than corneal gas permeable lenses. Another study that I thought was really cool, and again, this one is about vision, published in the journal, or about vision with sclerals, published in the journal French Ophthalmology. What they were looking at here is a case series, and these are four of the six case series patients. You can see they all have corneal scarring. So they were looking at six patients who had corneal scarring, central corneal scarring. Um, if you look at the vision, you can see their vision without a scleral lens worse, vision with a scleral lens better. That's interesting. What I thought was so cool, and I think is the best take home from this study, is that they talked about, and they talk about it a little bit in the discussion, and it really kind of resonated with me. And I was looking back through, they were talking about the fact that sometimes we assume that a cornea has a limited visual potential because of a scar, and we make an assumption that it's because of opacification. And what they're sort of arguing is that it might be that these patients have higher order aberrations that can be corrected for. It's not just reduction in scarring that's uncorrectable through opacification. So bottom line, and they didn't sort of take it a step further and measure the HOAs over the top of the scleral, which they say is sort of the next step. So I think this opens a really interesting avenue to looking at HOAs in patients with scarring to see if we can improve them even better than we previously thought with scleral lenses. And I think that yeah, I think there's a lot going on with the HOAs. That's all I'll say about it for in the research this year, but a lot there. Okay, super interesting study. I'm going to have to go fast if I want to get through everything. This was looking at adhesion. So this is shifting gears a little bit away from vision and more towards health. So they were looking at the adhesion of acanthamoeba on scleral lenses. Now, just first off and foremost, this is an in vitro study. So these are not lenses on eyes. These are materials. They essentially had five different lens or lens types. They had a silicone hydrogel soft lens. They had a scleral lens. They had these flat lenses, so non-curved lenses. And then they had them with and without hydropeg coating. And so basically they incubated all of these with different strains of acanthamoeba and they counted the growth on the lenses. So this is really cool. These are scanning electron microscopy and images of the surface of a contact lens. And so I wish I could spend more time on this, but I'm going to kind of go through it quickly. You can just see that first of all, none of these lenses are completely flat and smooth. Certainly a flat lens is going to have less sort of ridges to it. But anyways, you can read this paper if you're interested in this. I want to get to sort of the take home and the bottom line here. They looked at these flat lenses, just ignore flat lenses. We don't make lenses that are flat, but if you look at any of the sort of literature and knowledge on microorganism growth, they will not grow on a flat surface. So that was sort of just used as a control. They compared the silicone hydrogel lenses to the two scleral lenses. Bottom line, without going through any of these numbers, they found that scleral lenses have less adhesion of acanthamoeba compared to soft contact lens SiHy materials, which makes sense. SiHys are soft materials. Curved surfaces will always have more growth than flat surfaces. So again, that's a little bit kind of tricky to interpret if you're reading this article, but don't worry about the flat surface versus curved surface. You can't make a contact lens that's a flat surface. It won't reflect light. And the hydropeg coating did not increase or decrease acanthamoeba adhesion. So those kind of being the main take-home conclusions of all those interesting articles. And now I'm going to spend a couple of minutes before I pass it off to Vivien talking about my favorite topic, because there have been a couple of publications on midday fogging. This is something that a lot of people have published on throughout the years. The papers that were published here in 2024, this first one here out of Roots Lab in Portugal. I'm going to kind of skip over this slide here and just get to the bottom line. Essentially, what they were doing is they looked at patients on whether or not midday removal and reapplication of a scleral lens had an impact on the surface quality of the lens, the fluid reservoir thickness, and the visual acuity. So this was not actually directly looking at midday fogging. They were looking at midday removal. They did find after removing the lens, they did soak it in solution for 30 minutes and then reapply it. They did find that when they looked at the tear film surface quality score, which they used the Medmont for, they saw an improvement, lower scores here on the chart, an improvement in the surface quality. I'm going to skip this and just give the main conclusions here. They found that removal, cleaning, and reapplication of the scleral lens improves the surface quality. The fluid reservoir thickness, they basically found that there'll be somewhat of a footprint after the lens has been on the eye, but if you remove a lens and reapply it, you're going to get a little bit of an increase in the fluid reservoir thickness immediately on reapplication. They did not find any clinical change in acuity. So I think the big thing is you can help patients who have more front surface wettability issues by maybe a midday removal and conditioning with those. There was also a study by Jen Voigt and her friends, which we'll talk about later too, and they looked at lens and solution properties in patients with midday fogging. Ultimately, they looked at about 50 participants. They looked at several different things, but basically they looked at subjective reports of midday fogging and then a bunch of different parameters on their lenses, the solutions that they stored them with. Bottom line, they had over half of their subjects actually reported midday fogging. No predilection for gender. It was more common in ocular surface disease. You can see about 44% of ocular surface disease patients reported midday fogging. And then they looked at a bunch of lens different parameters, did not find any associations with midday fogging. They also looked at different solutions. Now, keep in mind, they weren't testing, this study wasn't powered to actually test for different solution associations, but they ultimately did find that approximately a third of the midday fogging had some explanation by lens and solution properties, but there was no one specific property or solution that was attributable to MDF. The one thing that they did sort of come away with, which confirms from other studies, is that the ocular surface disease index, i.e. the dry eye score, was worse in patients with midday fogging compared to those without midday fogging. And then I have to talk about my article, which was published here in 2024. It's a little bit heavy, so I'm going to just do the highlights. We ultimately collect the fluid reservoir. Most of you have heard me talk about this from beneath a scleral lens because you've got midday fogging that has all this stuff in it and all these cells in it. But that was not the point of our study. The point of our study was actually to culture epithelial cells with the fluid reservoir collected from patients with midday fogging. The graph that just popped up is probably the most relevant, which basically showed that there was a slight relationship, not significant, but a slight trend in an increasing level of inflammation in corneal epithelial cells when cultured with increasing levels of midday fogging. However, I will say in general, the fluid reservoir did not cause a huge inflammatory response of the epithelial cells in culture. It was more similar to when we treated them with just media, which they like, than it was when we treated them with the inflammatory positive control. But midday fogging may provoke slightly more inflammation than the non-midday fogging samples, which makes sense since we know that there's elevated immune cells present in midday fogging. Okay, and this last study I am not going to go through. I am about ready to pass it over to Vivien, but this is a study that I think was very timely this year, looking at this was a review article by Sharon Chiu and the people at Waterloo, looking at scleral lenses. They basically did a systematic review of scleral lenses with dry eye disease. I am not going to talk about it because this is going to be presented at the International Forum for Scleral Lens Research, which is our research meeting that is in January, the day prior or the day of GSLS starting on Wednesday, January 15th, I think, this year, whatever that Wednesday is. But hope to see many of you in attendance for that. You can register on the GSLS website. And with that, I think I managed to get everything in that I wanted. So I am going to invite Vivien on to share about some of her hypoxia and IOP research.
Hello, hi everyone. My name is Dr. Vivien Say, and thank you for the invite to join this research group. So today I'm going to be talking about updates on Scleral lens research regarding corneal hypoxia and intraocular pressures. And let's see if I can get this. Okay, very good. Okay, so scleral lenses are increasingly used to treat a wide variety of ocular diseases. Concerns about corneal hypoxia during lens wears continue to be the subject of ongoing research. Now, these concerns originated from theoretical models that propose optimal fitting parameters to prevent hypoxic events and emphasize the importance of lens oxygen permeability, lens thickness, and scleral tear clearance. Now, while assessing corneal thickness changes at the central is important, evaluating peripheral corneal thickness is equally significant. This is particularly relevant because the lens thickness and the tear reservoir of a scleral lens varies as the distance from the center increases, potentially affecting oxygen transmission to the different areas of the cornea, especially closer to the limbus. Now, the Clinical Research Center at UC Berkeley, which is a research group that I'm part of, did publish a theoretical model in 2020 that estimated the corneal swelling at the peripheral cornea with contact lens wear. This model compared soft contact lenses indicated as SCL with scleral lenses indicated as SL and in different lens oxygen permeability values shown in the figure on the left. The model showed that with the limbus, as seen with the solid lines, reduced corneal swelling in the peripheral and mid-peripheral regions, despite the thickness of the contact lens periphery. Now, the figure on the right demonstrates that a supply of oxygen from the limbus actually has a minimal effect on the peripheral corneal swelling. In contrast, metabolic support, which involves the supply of bicarbonate and removal of lactate ions from the limbus, has a more significant impact on peripheral corneal swelling. So the first study I'm going to be discussing will be they compared corneal swelling at both the central and peripheral locations after 90 minutes of scleral lens wear. Now, this research involved 10 young, healthy subjects who wore scleral lenses fitted with low, medium, and high fluid reservoir thicknesses on 3 separate visits. Now, the researchers used spectralis OCT to measure the fluid reservoir thickness and corneal edema with a scleral lens on the eye. Now, due to the potential impact of conjunctival prolapse on peripheral corneal epithelial thickness measurements, the study focused solely on stromal thickness values. It's worth noting that previous studies have confirmed that corneal swelling induced by scleral lenses are primarily affects the stromal blade. Now, looking at the top figure, stroma edema is shown on the y-axis, and the x-axis indicates the distance from the central cornea. The color lines represents the different fluid reservoir thickness, with green as low, the orange is medium, and the red is high. Now, this finding shows that there is a significant increase in both the central and peripheral stroma edema as the fluid reservoir increases from the low to medium or high values. Interestingly, when comparing regional differences in stroma edema, looking at the table on the bottom where you're comparing the nasal versus temporal and central versus the peripheral, the results were similar across all the fluid reservoir conditions. The current study findings on the central and peripheral corneal edema were consistent with previous studies where their findings are listed in this table, which also found no statistically significant differences in corneal swelling between the central and the peripheral cornea. However, unlike the previous research, this current research identified an association between fluid reservoir thickness and peripheral corneal swelling. But there are several key factors that we need to consider when we're comparing the current study and the previous studies. One is the instrumentation. The equipment used to measure corneal swelling varied across these studies, potentially affecting the comparability of the results. Second is the timing of the measurements. So the previous studies listed here, they obtained peripheral cornea thickness measurements after the lens removals, whereas the current study measured it before the lens removals. Now, this timing difference may have led to an underestimation of the peripheral edema in earlier research, as some swelling could have subsided during this delay. In addition, though, measurements taken with the OCT images on the scleral lenses on the eye in this current study may be distorted due to the thickness and the curvature of the scleral lenses, potentially affecting the measurement accuracy. In addition, the current study specifically measures stroma edema, which can result in a slight overestimation compared to measurements of total corneal edema used in previous research. Now, another aim I wanted to focus on about this study was that it compared the amount of corneal edema at the center peripheral to the previous theoretical model that I mentioned earlier, and is shown in the left figure. So the orange line represents the current study, while the blue line shows the theoretical model without limbo-metabolic support, and the purple line with the limbo-metabolic support. The peripheral corneal swelling observed in the current study follows the same trend as the model without limbo-metabolic support. However, a direct comparison cannot be made between the theoretical model and the experimental data due to several factors. One significant difference is the lens thickness profile. So you see that on the top figure on the right, the lens thickness of the current study is showing that it increases as it moves further away from the center. And in contrast, the lens thickness of the theoretical model shown in the bottom right figure increases in the mid-peripheral and then decreases. Additionally, the lens oxygen permeability values used in the two studies differs. And furthermore, the current study reports stroma edema values, whereas the theoretical model presents total corneal swelling values. So the next study I want to talk about is that it's comparing central corneal swelling between a standard scleral lens and a reverse piggyback system after 9 minutes of lens wear. Now, reverse piggyback system consists of a soft contact lens placed on top of a scleral lenses. Now, clinicians, we may benefit from prescribing the reverse piggyback system to our patients because a soft contact lens may provide better lens surface wettability. Now, this research involved also 10 young healthy subjects who wore two types of the scleral lens systems for 90 minutes each on 2 visits. The researchers also used a spectralis OCT and they took the measurements with the scleral lens on the eye. The soft contact lens used in this reverse piggyback system was the Alcon Dailies Total 1, which is known for its high oxygen permeability lens material. And as you can see indicated in the red circle on the right, if you're looking at the p-values, you notice that there was no significant differences in corneal swelling between the two scleral lens systems. So this finding does suggest that the highly oxygen permeable reverse piggyback scleral lens system did not induce a clinically or statistically greater magnitude of central corneal edema compared to just the standard contact lenses, but in young, healthy adults. So most of the studies that I've talked about just now have been focused on young, healthy eyes. However, it is important to consider research on eyes on compromised corneas as well. So this next one is looking at the magnitude of corneal swelling across the entire corneal surface in patients diagnosed with pellucid marginal degeneration. This study involved 14 eyes, and they were all fitted with scleral lenses for 6 hours. The researchers used a Pentacam HR system to measure corneal thickness changes before and after scleral lens wear. Now, the results are shown in the figure on the right. We're showing a range of percentage of corneal swelling ranging from 2.1% to 4% after 6 hours of wear, which is all within the range of normal physiological corneal edema under closed eye conditions. And the average central corneal swelling was about 2.6%, but is found to be statistically increasing from the center to the peripheral. In addition, though, a Pearson's correlation analysis revealed that there was no association between the corneal swelling and the fluid reservoir thickness. Now, besides examining corneal thickness changes and corneal edema, this next study expanded scopes to also include anterior chamber angle parameters. Now, the research involved 12 healthy Chinese subjects who wore lenses for 2 hours and 4 hours on 2 separate visits. To measure multiple parameters as shown in the image, the researchers used a wide field swept source anterior segment OCT. Now, this instrument is able to measure several key parameters, such as central cornea thickness, anterior chamber depth, angling opening distance at 500 microns anterior to the scleral spur, and the trabecular iris space. Now, this table is showing the mean and standard deviations for each of these parameters. The values circled in the red is indicating the statistically significant findings. An important observation to note was that there was a significant increase in central cornea thickness at 2.29% after only 4 hours of wears, but not after the 2 hours of wears. In addition, there was a significant decrease in the anterior chamber parameters after 4 hours of wears. Now, these significant decreases in anterior chamber parameters suggest that a scleral lens may be compressing on the anterior chamber and potentially affecting the aqueous humor outflow. However, IOP was not assessed in this study. Therefore, further research is warranted to better understand how the changes in the anterior chamber angle parameters correlate with potential IOP changes during scleral lens wears. So this leads to the second topic in scleral lens research, which is intraocular pressures. As we all know, many clinicians do speculate that because of the large size of a scleral lenses and where the lens edge sits on the conjunctiva and scleral, it may lead to compression of important ocular structures, part of the aqueous humor outflow. And this raises concerns that the scleral lenses might potentially elevate IOP. And when we're assessing IOP changes in scleral lens studies, it is crucial to always consider the type of instrument used for these measurements. The instruments all shown here above are commonly used in both the clinical practice and also research setting. However, a significant limitation of these instruments is that the scleral lenses must be removed before taking these measurements. This creates a delay between the lens wears and the IOP measurement, which can affect the accuracy of the results. So the first study I'll be discussing was conducted at the research group where I'm at, and we assessed IOP changes during 5 hours of scleral lens wear, and this research involved 30 healthy individuals who wore scleral lenses of 2 lens diameters on 2 separate visits. To establish a baseline, we also assessed IOP variability during a 5-hour period. On a separate visit without any lens wears. Now, in this study, we use a pneumotonometer to measure IOP because we're able to measure it at the scleral before, during, and after the 5 hours lens wearing period. Additionally, IOP measurements were taken at the cornea before and after lens wears. Clinical studies have shown that IOP measurements obtained with a pneumotonometer is closely related with true eye pressures in both in vitro and in vivo settings. Importantly, IOP measurements taken at the sclerals using this instrument shows a strong correlation with those taken at the cornea. This figure shows us key significant findings from our research. The y-axis is the scleral IOP and the x-axis are the time points. Now, this figure shows a statistically significant increase in scleral IOP for the 2 lens sizes at the 2.5-hour time point after lens insertion. The average increase was about a 1.16 millimeters of mercury for smaller lenses and 1.37 millimeters of mercury for the larger lenses. Additionally, we investigated the correlation between the corneal and scleral IOPs in our study populations. In our analysis revealed that about a 1 millimeters of mercury change in scleral IOP corresponds to about a 0.3 millimeters of mercury in corneal IOP. Therefore, the observed scleral IOP increases of 1.16 and 1.37 translates to about a corneal IOP change of 0.3 to 0.4 millimeters of mercury, which is showing that these changes are likely not clinically significant. The next study I will discuss also assess IOP changes in 30 young healthy individuals, comparing two different lens diameters as well. In this study, the subjects wore the scleral lenses for 2 hours in the right eye, while the left eye served as a control. The researchers in the study used two distinct instruments to measure IOP. One was the Perkins tonometer to measure corneal IOP before and after lens wear. And the second one, they use the diatom transpalpebral tonometer to measure IOP while the scleral lens is still on the eye. So the top table presents the mean and standard deviation of the IOP measurements using Perkins in both the study eye and the control eye. Then below this is a diagram that illustrates the changes in IOP as measured by diatom. Results that are statistically significant are highlighted in red. Now, when you're using the Perkins, there was a slight increase of 0.46 millimeters of mercury observed with a smaller lens only after 2 hours of wear. In contrast, the diatom tonometer revealed a statistically significant increase of approximately 2 to 2.5 millimeters of mercury during 1 hour and 2 hours of lens wear for both the scleral lens sizes. However, it is crucial to note that IOP measurements taken with the diatom are obtained from the upper eyelid rather than directly on the eye itself. And this distinction in the measurement technique should be considered when interpreting these results. In addition, the study also used a swept source anterior segment OCT to measure iris cornea angle and the Schlemm's canal's parameters. The left table reports the changes in the Schlemm's canal parameters, while the right diagram presents box plots showing the changes in the iris cornea angles. The red stars in the diagrams indicate statistically significant findings. Now, for the corneal angle parameters, significant decreases were observed with the smaller lenses. In contrast, most of the decreases in the Schlemm's canal parameters occurred with the larger lenses. However, when we're comparing these findings to the IOP changes, the study suggests that the small changes that we're seeing in the anterior chamber angle parameters and the slight increase in the IOP did not appear to be clinically relevant for these subjects. Okay. So this is the final study I'll be discussing, and it was a longitudinal 12-month study that compared the IOP changes in 70 eyes with irregular corneas and 21 eyes with regular corneas. And in this study, the researchers used the ocular response analyzer to measure IOP and also assess for corneal biomechanical properties, including corneal hysteresis and corneal resistance factor. Now, this device is a non-contact tonometer that can provide two IOP measurements. One is the Goldman-associated IOP, and the second one is the corneal compensated IOP, which accounts for variations in corneal thickness and biomechanical properties. The primary finding of the study was that there was no statistically differences between all the visits for all the ORA parameters in both the study groups. Now, while these findings are promising, further research is warranted to better understand IOP changes during scleral lens wear, particularly in patients that are more susceptible to IOP fluctuations, such as those with glaucoma. So such of these studies could provide valuable insights into the long-term safety and management of scleral lens use in a diverse patient population. So I'm gonna take it away to Dr. Gloria Chiu.
Awesome. Thank you so much, Vivien and Maria, for sharing all these amazing studies. I'm going to go back one, and here we go. So I am very happy to be with you this evening. Over the next 15 minutes or so, I am going to be sharing updates from the SCOPE study group, which you can see these beautiful ladies here having dinner at the American Academy of Optometry in Boston, and also on some shape and ocular surface-related studies related to scleral lens wear. So what is the SCOPE study group? This stands for scleral lenses in current ophthalmic practice evaluation. And this group formed 10 years ago in 2014. To date, they have published 23 papers together, and this number is continuing to grow. Their focus is to provide a better understanding of the role and performance of scleral lenses in clinical practice. So a lot of their studies have just been so relevant and interesting to me and all of us who fit scleral lenses on a daily basis. Members of this group are showed here: Dr. Amy Now, Sherry Now, Ellen Shorter, Jennifer Vogt, Jennifer Harthan, and Muriel Shornack. Very amazing, prolific, intelligent, and brilliant group that has taught us so much. So in 2024, they published 6 studies, which I will be sharing now. The first is here, reporting on patient experiences with contact lenses and dry eye disease. So many of the SCOPE studies are survey-based, as was this one here. All of the surveys were conducted through the Dry Eye Foundation. There were over 600 respondents, the majority of them from the US. And one thing I found very interesting here was that it was predominantly female. So we have over 500 females and only 90 males. And of this group, 15% used therapeutic soft or scleral lenses. So not the majority of patients with dry eye. And also of note, 72% of the scleral lens wearers spent more than 20 minutes a day on managing their dry eye. And there was a less percentage of soft lens wearers. So we kind of know this. There's a lot more manipulation, handling, solutions, possibly a midday clean for midday fogging. And also interesting, the annual median expenditure was higher for scleral lens wearers, about $1,500 a year, versus soft lens wearers $700 and non-lens wearers $500. So that was very interesting here. And also all of the mean OSDI scores in this group had severe dry eye. The next survey-based study here was based off of the same study, but looked at specifically dry eye treatment and the burden of care in patients. So again, over 600 people involved. And interestingly, they found that artificial tears were the primary treatment for dry eye. And I feel like, we all can probably agree with this. When a patient tells you dry eye, we whip out our list of favorite drops and tell them where they can purchase them. And I feel like this is kind of an opening for us to know that we can do better. Although artificial tears were the primary treatment, in the second tier came warm compresses, gels, and ointments. And then after that, less common were the topical prescription drops, cyclosporin, cautery, and topical steroids. So also, the surveys reported that ophthalmologists provided the most dry eye care, although half the patients reported that their eye care provider was not their primary source of information. So we need to be aware that patients are getting information from social media, Facebook, Instagram, TikTok, and we need to kind of ask what they know and what they feel is true and make sure to educate them appropriately. The next study here is also survey-based from online surveys from keratoconus and contact lens society groups, and describes the availability and usage of scleral lens fitting technology, particularly in keratoconus patients. So 423 practitioners participated here. And I practice in a hospital in the Department of Ophthalmology. And so I know that Vivien and Maria also practice at institutions, particularly optometry schools. This study found that image and impression-based technologies were more frequently available in academic practices compared with community practices, and also in high volume, meaning more than 60 fits, compared to low volume practices. And I guess that makes sense because you're teaching, you're learning, and particularly in these academic settings, we may be allowed perhaps a little bit more time because we're teaching students to work on these more complex fits. Most participants, however, reported using diagnostic lenses to fit scleral lenses for their patients with keratoconus. And for myself, I feel that that's true as well. I tend to reach for diagnostic lenses from various companies, and most of the time I can get pretty great results. Although I sometimes use profilometry, I'm still trying to fine-tune my image capture in those really advanced dry eye patients, and also learning, how can I better utilize this technology, which the next couple of studies look at here. So this study, which took results from a similar survey, looked at image and impression-based technology for scleral lens fitting, but looking at, how efficient can this make a practitioner? So it used electronic surveys, and they found no difference in the median time required for initial evaluation, about 30 minutes, or, and this is kind of what's practical to us in clinic, or the median number of lenses ordered during the fitting process, which was still about 2 lenses, whether it was diagnostic fitting, image-based, or impression-based fitting methods. Median time to acquire images was about 10 and 15 minutes, and images obtained were adequate for a lens order 80% of the time with images versus impressions about 90%. So I've struggled with this myself. I had a couple patients with SJS and just severe dry eye, and I really struggled to getting accurate image capture, and I think that's something that we can all continue to improve upon. So in the end, they found that practitioner reported efficiency of scleral lens fitting was similar between diagnostic, image-based, and impression-based methods for these patients. And one thing that I really appreciated that they highlighted is that technology-assisted fitting doesn't eliminate the need for astute clinical knowledge. So we still need to know how to manage our keratoconus patients. Do they need cross-linking? Are they progressing? Do they have dry eye? So we need to look out for those as well. They had 2 prospective studies out of the scope group. This was one that looked at process and outcomes of fitting corneal scleral profilometry-driven lenses for patients with ocular surface disease, so moving away from keratoconus. This prospective study looked at scans acquired from 9 patients and 15 eyes. Mean scan took about 10 minutes per eye, and there was a mean of about 2.9 follow-up visits required to complete the fitting. So about 2 lenses ordered per eye. And so this shows that even with advanced technology with profilometry here, the number of lenses and follow-up visits required were similar to outcomes from previous studies that described essentially fitting with diagnostic lenses. And again, imaging technology doesn't negate the need for skilled clinical observation, especially in these dry eye patients. We're dealing with more than their eye shape. We're dealing with tear film abnormalities, mucus, increased inflammatory mediators, and we must remember to treat those in addition to fitting a piece of plastic. This study, Maria already reviewed, but I wanted to include it because it was from the scope group and, of course, midday fogging. So again, she found that in these wearers, scleral lens wearers with midday fogging essentially had similar symptoms to patients with severe dry eye. And there weren't, none of the factors alone really had a significant impact on midday fogging when they looked at lens parameters, material, coatings, diameter, and lens storage and filling solutions. So now moving into some studies involving scleral settling and shape. And all of the next studies here are from outside of the US. Again, a lot of the scope studies are based on surveys conducted with practitioners in the United States. This study here is out of Australia. And I think many of us can relate to this. How many of us see those lenses that go down and out, right? No matter what we do. Well, this study looked at the effect of lens and fitting characteristics upon scleral lens centration. So what's causing that? So they quantified the impact of varying central fluid reservoir depth, lens thickness and mass, and also looking at a peripheral fenestration. This was in 10 young healthy adults for 90 minutes. And they concluded that medium and high vaulted lenses with that deeper fluid reservoir conditions actually resulted in more temporal and inferior lens decentration compared to lower fluid reservoir depths. So about 0.17 millimeters temporal and 0.55 millimeters inferior. So if you're struggling with that decentration, you might try to reduce the vault a little bit. So yeah, I thought that was very interesting here. Also, we know already that lenses sink and settle into the conjunctiva. A lot of studies have demonstrated that. This study came out of China, looking at the settling characteristics of lenses in Chinese adults with refractive error, so no corneal disease, to provide guidance here for clinical application in their communities. These were 21 healthy Chinese adults, late 20s, and the average spherical equivalent was about minus 5.5, and they were fit with a 15.6 millimeter diameter lens, and they looked at the central post-lens tear thickness. So they found, as we would expect, the amount of settling varied among individuals between 70 to about 200. And this is interesting because remember, these are healthy adults that are pretty young in their late 20s. And so we're still seeing a wide range of settling. And they found that after about 4 hours, settling was about 126 microns plus or minus 33. They also found in this study that practitioners could estimate that post-lens tear thickness using this prediction model, this equation, which we definitely don't have enough time to discuss. But you can see in the graph on the right that looking at it, you see that time is on the x-axis through 4 hours. And the majority of the settling happens in about the first hour. But you do see more settling even through 4 hours. So the first hour you see the most, and then still going through 4 hours, you see a little bit more settling into the conjunctiva. So make sure you fit with enough clearance so that we don't end up hitting our cornea and compromising the epithelium. This study came out of Turkey and looked at the effect of extended periods of mini scleral lens wear on the conjunctival and episcleral and scleral thickness. So with our patients wearing these lenses that sit on the conjunctiva, are we causing perhaps anatomical or physiological changes? So they looked at these parts of the eye in patients with keratoconus and used anterior segment OCT in 17 patients and 17 eyes. They had 3 groups. We had keratoconus patients with mini scleral lens wear, keratoconus patients without lens wear, and then healthy controls. And they found that mini scleral contact lens usage causes thinning in the conjunctival episcleral layer, particularly in the top and bottom areas, but did not affect scleral thickness. So something to keep in mind as we're fitting more and more patients now starting young. Could this potentially have, anatomical or physiological consequences in the future? And then this last paper here comes out of India. I know that many of us struggle with cicatricial conjunctivitis and severe keratopathy, particularly when our patients have conjunctival scarring and symblepharon. Here's a picture of a patient of mine with Stevens-Johnson, and it's really difficult to fit around their symblepharon. And this study looked at the impact of symblepharon management with ocular surface reconstruction on scleral lens fitting in eyes with these cicatricial conjunctivitis and keratopathy. And they described essentially the importance and role of symblepharon release with ocular surface reconstruction to improve fit with scleral lenses. And they looked at improvement in visual acuity as their outcome. This is out of the LV Prasad Eye Institute. They looked at 29 patients who had SJS, ocular burns. And a couple interesting things they noted were that the most common location of symblepharon was superior in 59% of patients, and limbal involvement in most eyes. They found that the median time between the surgical manipulation and wearing the scleral lens again was about 15 weeks, and that symblepharon recurrence was noted in 70% of eyes that underwent amniotic membrane grafting, but no recurrence was seen with mucous membrane grafting or conjunctival autografting. So if fits start to get really challenging with that peripheral symblepharon, it's possible to work with our corneal surgeons and see if they might be willing to do some surgical intervention, but just be aware that sometimes the scar tissue does grow back, sometimes even in different places and more aggressively. So this is always a challenging group of patients to work with, but the more we share experiences with each other, maybe we'll continue to improve, especially with advances in scleral profilometry, as well as impression-based molding fitting techniques. Hopefully, we will continue to see advancements in scleral lens fitting as we continue to move forward.